So with your permission, shall I start, sir?
Yeah, please start.
Sir, I'm presenting the case of Mrs. XYZ, who is a 44-year-old Hindu female hailing from Whitefield, Bangalore. She resides with three other family members in a nuclear family. She's an IT professional by occupation and earns 1 lakh per month. That's a total family income. And she's completed her post-graduation. The socio-economic status is upper class as per modified Kupuswamy classification, and Mrs. XYZ is a known case of hypertension since 2 years and is on medication for the same. Patient was apparently all right 2 years ago. She then had complaints of recurrent episodes of headache, which was sudden in onset, generalized, and was relieved on rest and occasionally by medication. She also had nausea, blurring of vision, and watering of eyes, which she attributed to long working hours and screen time. Routine health checkup revealed elevated blood pressure. Following this, a month later, two subsequent visits to the doctor revealed elevated blood pressure and she was diagnosed with hypertension. She was prescribed with medication for the same, however, was not compliant. 1 year ago, she complained of sudden onset of dizziness, palpitations, uh, vomiting, which were non projectile, following which she was admitted to the hospital. Patient says it was 180 over 100 millimeters of mercury. She was treated and discharged the following day. There was no history of seizure, no history of sudden loss of vision, chest comfort, pain, or difficulty in breathing, or loss of consciousness or weakness in any part of the body during that episode or even after that later on. She has no history of diabetes mellitus, asthma, or thyroid disease, and she's taking olmesartan 40 milligram and amlodipine 10 milligram, one tablet a day. She's compliant with the medication since 1 year, and she has been counseled on diet and exercise. There's history of hypertension in the family. That's with respect to her parents and two of her siblings. However, no history of diabetes. So, shall I continue?
Yeah. Shall we just discuss a little bit about the initial part that you have presented, or you want me to ask the questions at the end?
So we can discuss from the initial part itself, sir.
Yeah. I mean,
You can
I
go.
feel in that way it would be helpful to everyone so that we are going from step by step.
Yes,
Can you just go to the first slide? I mean, like first slide about the patient?
yes, sir.
Yeah. So here you are presented about the age of the patient, the religion, where the person is residing, and the family members, along with the occupation and income. So when you are looking at a clinical case versus a clinico-social case, what are the differences that you would find and why this information that you have taken is of relevance? Can you please explain that?
Sir, I'm sorry, the voice got cut in between. There's
Okay.
something wrong with
So
the internet.
what? Okay. So what I'm asking is, how is a clinical case different from a clinico-social case where you have taken the information on family members, occupation, and the family income? Why is it relevant?
So, in the clinical case, we would only be looking at the patient, sir, in terms of diagnosing and treating. But in a clinical social case, all the other factors which would have contributed to a disease, as in this case, which is hypertension, will become relevant. So, in terms of her occupation, sir, it is relevant to hypertension because as an IT professional, a sedentary lifestyle could be a contributing feature, a contributing risk factor. uh, then the family members, a nuclear family would mean that she would have more burden in terms of taking care of her children as well as with the work because she's working. uh, so what was the other part?
About the income, the total family income.
So the income would reflect upon whether they would be able to afford the medicines that is being given to them, the healthcare services that they would be able to afford, as well as it would reflect upon their the housing, the socio-economic status, and the lifestyle.
Excellent. So when you move to your second slide, you're talking about the, can you just go on to the next slide?
Yes, sir.
Yeah. So here you have written that the socio-economic status is that of an upper class based on education, monthly income and occupation, where they have got a score of 26. So is this score referring to the individual or is it referring to the family?
Sir, this is referring to that of the family.
Okay. So if the family were to be living in a rural area, what would be an appropriate classification for rural area?
So we could use BG Prasad classification, or we could also use Uday Parikh scale for rural area.
Okay. So why do you think that assessment of socio-economic status is important?
So socioeconomic status would have an impact on the lifestyle of the individual, sir. The diet that they would consume would have, I mean, socioeconomic status would have an impact on that as well. Then the housing conditions, the environmental conditions in which they live. Also, sir, the occupational risk factors which would be concerned with the disease in question, and also whether they would be, and another thing is with respect to education, it would determine how far they would understand what disease they have, whether there are any taboos or any misconceptions they have about a certain disease, and whether they would be compliant with their medications or not.
Yes, that's excellent, Priya. That's a good thing. In addition to what you have just told, so when you are looking at the socio-economic status, it is about accessibility to the care and affordability to the quality of care that they can access. So when you have in the first slide talked about the family structure and the family composition, usually we look at it from the vulnerable groups. So in this family, like, do you think are there any vulnerable groups?
No, sir. There are no infants or children. There's no one who's pregnant and there's no one who's elderly. But because the patient is hypertensive, then that would make her vulnerable.
Okay, by virtue of the morbidity of an individual, they can be vulnerable for certain components. So, like the first phase, what you have presented now is about the individual, the family composition, the socio-economic status, and which encompasses the education of the head of the family, the monthly income, and their occupation, which has a bearing on the health and well-being of that individual. So in any case, whenever you are presenting a clinico-social case, the additional component of the socio-economic status and these things will become important because unlike a clinical case which you tend to treat in an institution or only the disease per se, a clinico-social case is a more realistic way of approaching the morbidity because more and most people are treated outside the hospital except for an acute exacerbation or for an acute event where they will be required to be in the society or in their family and understanding from where they come and where they would be going after the hospital stay or the treatment part is very essential. So this forms the basis on which you build the clinico-social case and understand the determinants for the disease and also the determinants for the well-being of that individual in terms of treatment and the later components. So please proceed.
Yes, sir. So should I continue to the other slides, or
Yeah, the other slides, please. After the fifth slide, I guess. Yeah,
personal history, sir?
yeah.
The patient has a normal appetite with regular bowel and bladder movements. She gets 5 to 6 hours of sleep, does not smoke or consume alcohol, and takes brisk walks for 45 minutes every day, which she's been doing since a month. Her menstrual history is that she's attained menarche at 14 years and she's regular cycles of 28 to 30 days. With 3 to 5 days of flow and changes 2 to 3 pads per day. This is not associated with pain or passage of clots. The diet history based on 24-hour
Yeah,
recall.
Priya, can we just look at the previous slide and discuss a little bit there?
Yes, sir.
Now, so here, when we are talking about the personal history, again, like what we are seeing is one is with regards to the appetite, the bowel and bladder movements, the hours of sleep Do you think for this individual who is aged 44 years, an IT professional, 5 to 6 hours of sleep is adequate?
No, sir, it's not adequate. In fact, it can again turn as a risk factor for hypertension because uh, probably because of the stress component that is involved.
Yeah. So, like this 5 to 6 hours of sleep, is it because she is not able to sleep for a longer period, or it is like she doesn't get sleep? I mean, she tends to wake up early or sleep late.
It's because she sleeps late and wakes up early, sir. It's not with the quality of sleep.
Okay. So because that is something which is again an important for you to understand whether the sleeplessness is a consequence of the morbidity, underlying morbidity, or it can whether by itself accentuate the morbidity. So a lot of people with sleep disorders do have an association with both diabetes and hypertension, and largely related to this syndrome X, the metabolic syndrome that we see in individuals. So it might be related to that. So asking about the quality of sleep, the duration of sleep, and any kind of disturbances in the sleep pattern, rhythm, and the how long they sleep is of very important nature. And also with regards to the consumption of both tobacco and alcohol, because many a times you need to differentiate between again quantity, quality, duration of both the tobacco and nicotine consumption and alcohol consumption. So why do you think that it's important to know about alcohol and smoking as a personal habit in an individual?
So both of them are risk factors to a lot of non-communicable diseases. With respect to consumption of tobacco, it itself acts as a risk factor for a lot of cancers, for hypertension, because of the fact that it can cause vasoconstriction and then cause sympathetic overactivity. And another thing is that consumption of alcohol is a risk factor for obesity, for diabetes, for hyperlipidemias, which all have a bearing on the non-communicable diseases.
Okay, very, very good. So, and also with this history of brisk walk, we will just tag it here and come back to it when we are talking about the need for physical activity. And with regards to menstrual history, especially in a woman with, let's say, hypertension, why is it important to understand like whether the lady has attained menopause or not? Is there any difference that will happen post menopausal this thing with regards to hypertension?
So there's a higher prevalence of hypertension in women who are postmenopausal.
Is it prevalence of hypertension or prevalence of cardiovascular diseases?
Cardiovascular diseases, sir.
Yeah. So why do you think it would happen in the postmenopausal women?
Uh, so I'm not sure of the exact cause.
So what happens to the estrogen?
It falls lower in the after menopause, sir.
Yeah. So the protective effect that the estrogen would have had on the individual would be lost, and it equalizes the risk between males and females in a postmenopausal woman. So it is not actually higher, but it's the risk equalization that happens. So it is worthwhile to ask about the menstrual history and understand whether the person would be requiring some supportive thing. And also during the menopausal period, like there can be hot flushes and other things which can accentuate her underlying morbidity. So it is required for you to understand and treat that component if it is essential. Okay, please
Yes.
proceed.
So patient is a vegetarian. Her staple diet is rice. She has lunch at the office on weekdays, and she fasts once every week. And during the fast, she only consumes tea and water. So this is the 24-hour recall and the diet history that I've taken, sir. Uh, the total calories that she consumes in a day is 2,278 kilocalories a day against a required of 3,198. So there's a calorie deficit of 28 percentage, and the total protein she consumed in a day was 47.2 grams against a required of 78 grams. So the deficit there was 39 percentage, and she consumes 5 grams of salt every day.
Okay.
in her
So
diet.
here, so nutritional assessment is an important component both for clinical case and clinico-social case with regards to what they consume, how much they consume, and what is the variation in that consumption, which might have a bearing on the disease cause and disease effect, therapeutic. So in that context, when you have taken, what are the different types in which you can assess the nutritional history or the dietary history?
So one is based on the oral questionnaire method where we use the 24-hour recall and find out.
Okay.
Other thing is there is a the dietary survey which involves weighing the foods, the raw food and the cooked food.
Mhm.
That would be done for a period of 7 days as a cycle.
Okay. What is
Uh,
inventory method of dietary assessment?
I'm not sure of this, sir.
Okay. So basically, you ask them what they buy, and that is the inventory. Suppose there are four people and they are buying, let's say, 8 kgs or 6 kgs of rice, 2 kgs of dal, and 2 liters of some edible oil. So you will be able to know that with this given inventory, which is being consumed by four people over a period of, let's say, 1 month, again, you will be able to get a guesstimate of what is being consumed. So that is the inventory method. Apart from that, when you are this weighed food and cooked food, it's not so easy unless you are very clear about the quantity of how much and how frequently they are consuming. It would be difficult. So usually what we have is standardized cups and the standard size of the roti, if at all, if it's the chapatis or the rotis that they are consuming, because the size can vary between each household. Some household can make a very small pulka kind of a thing. Another household can have a large chapati, and two will be equal to four of another size. So in that sense, the National Institute of Nutrition in Hyderabad has come up with standards for assessing the nutritional and the dietary consumption, and they have these cups and sizes which give you an equivalent in terms of calories. So if they are saying the upma 2 cups, so the cup size is standard, and you will be able to know that cooked semolina or the upma thing will be equivalent to these many calories, and the protein from that table is what you have taken. So standardization of consumption using measures is extremely important. And also with regards to this consumption of beverages, when you say that tea, it's a very like complex thing. When you are actually assessing it, for the uninitiated, the tea can be a tea. But when you see that, like whether it is with milk, with added sugar, you'll be surprised that the variation in the caloric consumption can be tilted by 10 to 15% if you miss out on how much sugar they add for the tea, and whether it's with milk or without milk, and how frequently they consume the beverage. So it's important to take that as a component and actually ascribe a value to it and calculate it. So please move to the next slide, please.
Yes, sir.
Yeah, next slide. Yeah. So here you have told that total calorie, the previous one. Total calories consumed is 2278. By and large, a 24-hour recall method will be having some issues because of it might not be the typical, or it might be varying with regards to the day of the month, or if there is a festival, or so many other confounding factors can be there for this particular component. But when the next thing is what is a little bit questionable, total calories required. So, like the calorie requirement is based on recommended dietary alliance, which is again given by an ideal man or a reference man and a reference woman, who will be described in terms of the weight, the activity, what they will be doing, what component of the hours they sleep, they work, they walk, or they do the exercise. Based on all these things, the RDA would be given for a given individual in what kind of work. So, how do you classify this lady, 45-year-old, 44-year-old software IT professional as? Is she a heavy worker, sedentary worker? How do you, or a moderate worker? How do you classify?
So I would classify her as a moderate worker, considering that she is also doing exercise since a month.
Okay. So the doing the exercise has got nothing to do with how you calculate, I mean, like how do you classify that person? Because exercise is more of a additional activity and not the routine activity. Uh, so as an IT professional, where does it come? So does it come under heavy work, moderate or sedentary?
Sedentary, sir.
So it is a sedentary work. And is there any physiological components that would require her to take any additional calories, like pregnancy or adolescence?
No, sir.
No. So in that context, if you calculate, and what was her weight?
78 kgs.
78 kgs. So if you look at the sheet, recommended dietary allowance sheet, so it says that, I mean, like for a reference body weight of 55, for a woman, 2230 kilocals per day is what is required. So I'm curious to know how you got this number 3198. Or is it been sort of like a typo where the total calories consumed is 3198 and what she's supposed to take is 2278?
Sir, I've calculated it that way.
Okay. Because calorie requirement, even for a heavy worker male, it comes to 3490. So certainly like for this lady, it won't be 3198. So it would be in the range of 2230. And if she's a heavy worker, 2860 along with 350 if she's pregnant and 550 if she's lactating for 0 to 6 months. So please go back and check what is the total calorie required and you can calculate it. And also with regards to the protein requirement, you have calculated it as 1 gram per kg body weight, right?
Yes, sir.
Yeah. So the protein requirement versus the protein consumed, that deficit usually will be very wide when you are taking the 24-hour recall method, because we wouldn't have sort of like ask about so many other things which they might have consumed. So in that context, there will be an underestimate of it. How do you verify whether the deficit, if you say that there is almost a 40% deficit in the calorie and the protein, how do you verify whether the deficit is being reflected in that individual? How will we know that?
So by the anthropometry, sir, like the BMI of the individual might reflect onto.
Absolutely. Very
Uh,
good. Right, Priya. So when you're looking at the anthropometry for this person, is there a weight deficit, a height deficit, hip waist ratio, and the waist ratio? So among this or the BMI, is there any deficit that is being sort of like correlating with a 40% calorie and food reduction?
no, sir.
Okay, so this is very important for others who are on the this thing like class now. Please be aware that like this is a very common kind of a thing that happens. You would have done very diligently the 24-hour recall method in the field and you would have calculated that it comes to a particular quantity. But when you actually see the weight, actually see the hip waist ratio and the BMI, in fact, surprisingly, the BMI would be high and tending towards pre-obese or obese in certain cases. So in that context, the examiners would like to know that like, why is this? There is a difference. So you should say that probably by 24-hour recall method, we have not been able to accurately get the calorie and the protein consumption. However, upon anthropometry, which is an indirect method of assessing the nutritional status of the individual, there is no energy or calorie deficiency that is being shown. And in fact, there is a overweight, which can be an indicator of excessive consumption of nutrients or fat without adequate physical activity to burn the same. Okay, so please proceed.
The environment history.
Okay.
So it's her own house with 2 rooms, and the house is a pakka house. There's no overcrowding. Lighting and ventilation are adequate. with cross ventilation. There's an attached kitchen with cooking platform, and LPG is used as a source of fuel. Refrigerator is used to store food. The water supply is continuous through pipe water, and there's a water purifier to purify it before drinking. The patient washes hands before cooking, serving food, and after using the lavatory. There is an exclusive lavatory in the house. The waste is segregated and disposed, which is collected every day. There are no sites of stagnant water around the house, and the distance of the nearest health facility is 1.5 kilometers
So
from
we'll
the
stop
house.
here. Yeah, we'll just, can you go back to the previous slide, please? Yeah. So when you are talking about the environment history, we are referring to the physical environment of the person where he is staying. And it is very essential that you link the physical environment with that of the morbidity that you are talking about. Uh, in that sense, like when you are saying that this is a case of hypertension. So when you look at stressors, which might have a bearing on the individual's mental health or psychological health or the well-being, it will be relevant to know the locality of the house, the ambient noise, the surroundings, which will enable the person to sort of like have a normal physical and psychological well-being. So in case if the house is let's say next to a railway station, a railway track, or in the busy marketplace, there have been several studies to show that there is some way where the person gets acclimatized, the Pushpaka Vimana kind of an effect, where without that noise, the person doesn't get a sleep. So that thing does happen, but at the same time, if there is continuous noise or something which is annoying, both physical environment and the place where the person is living, if it is not congenial for this health and well-being, that would be reflected. More importantly, if there are any changes in the physical and the psychological environment of the individual within the last 3 months or 6 months, or any acute change, so to speak, and you look at the morbidity, that linkage is something which you can connect and link. So usually among children, when they move from one place to another, like suppose the parents or the father is having a transferable job and the child has to shift from one school to another school frequently, then the residential environment and the peer group or the socialization of the child might not have happened, and that stressor will be reflected in learning issues, language development, and so many other things. So similarly, when you're talking about an environmental history, these components have a bearing. So when you say about overcrowding, so how do you sort of like assess overcrowding in a given house?
So one is based on the number of rooms, the other one is based on the floor space area, and one more is the sociological overcrowding.
Okay, so these are the three components. One is physical, second is physiological, that is like how many people are required to share a room. Third is sociological, where two people, not husband and wife of the opposite sex, beyond the age of 10 years, if they are constrained to share a room, the bedroom, then that is sociological. Physical, what is the square area or the space that is required for by person and room?
For two people, it's 110 square feet of area that is required.
Okay.
For one and a half, it can be between 90 to 110, and for one person, between 70 to 90 square feet
What do
of
you mean by
space.
one and a half?
So, half refers to a child, sir, which is more than 1 year of age, between 1 year to 10 years.
Okay, okay. So usually for computing the physical space requirement, less than 10 years, you are going to use it as half. But when it comes to calculating the Kubuswami classification, it is considered as a full unit, because like the consumption of the resources will be there for the child as well. Fine. So with regards to lighting and ventilation, so when do you say the lighting is adequate in a house?
So, on standing in any corner of a room, if the person is able to read fine print, then it's said to be adequate.
So, how, I mean, see, the questions what I'm asking are all standard stock questions. So, when you say that fine print, when do you say fine is fine? Is there a much more simple and practical way of classifying that fine?
Like reading a newspaper.
Yeah. So usually the font size of a newspaper print will be 7 to 7.5 times New Roman in Indian Express or Times of India, that kind of a thing. So if they are able to read at the center of the room without artificial lighting, because that is a very important thing. So these are all something like trick questions which examiners release to ask, saying that like, what if there is a light, or if they are reading it on the mobile. So that was a new thing in a couple of exams. So reading a printed newspaper in the middle of the room with natural light, if it is possible, for a person with normal vision or using the reading glasses. This completes the entire definition with regards to lighting. So when it comes to ventilation, when do you say the ventilation is adequate?
So there should be at least two windows in the house, and it would. So I'm not sure of ventilation though.
Okay. So when you say two
Air.
windows, again, the question is one window in the kitchen and one window in the living room, or it is in the same room. So it is in the same room. Either they should be placed on the adjacent walls to ensure cross ventilation. So the air exchange is what we are looking at. So the air should enter from one side and should be able to leave from a other side, so that the internal air quality is going to be sort of like appropriate and adequate for that particular area. And also the size of the window is extremely important. It should be one third the size of the wall, and it should be placed in the adjacent walls so that the cross ventilation is done. And also these windows should be openable, and there should be adequate setback of the house, because that is an important component. If the houses are just placed one house very close to another house, then there won't be any movement of air. So the setback refers to the spacing between the two houses, which will allow for entry of air and exit of air from the natural airflow. So you would also be required to know about some of the components, such as corrected effective temperature, ambient temperature, humidity, and how you measure each of these things. Because from the practical point of view, you'll be having these instruments that are kept as spotters in the practical exam, and they will be asking a question or two on those things. And also a little bit about air conditioning, because you can have a fan in summer months, but how does air conditioning is superior to that of just a fan? So if that's the question, how is AC better than just a fan?
So because air conditioning also removes or filters out the pollutants as well. Some of them it can even filter out the bacteria before it is released into the room. And another thing is it also the temperature is also not. I mean, one can control the temperature as well as the humidity using the air conditioner.
So that is important. See, bacteria and other virus filters, you please don't even mention, because in domestic environment, we won't be having HEPA filters fitted onto the air conditioning. It is only in hospitals where we require that level of safety. There will be high energy particulate filters which will be used. But in domestic, I mean like air conditioning, predominantly, because now some of the ACs are coming with it, but predominantly the air conditioning will be, yeah, not just the temperature, but also the humidity and the moisture content, which will control the air exchanges, because it is not just a passive push, but it's an active pull and push, where the freshness of the air will be there, and also the number of air exchanges for the given space will be adequately managed. All right. So
Yes, sir.
that is this thing. So somebody has told that Deepak, that we need to comment upon the air changes as well. Air change refers to the air, number of times the total volume of air in that room is being replaced by fresh air. So, and that can be usually measured in a controlled environment using AC. In an uncontrolled environment, it is very difficult to measure, but by thumb rule and some of the studies have done saying that if there are two windows of this size and if the air velocity is this much, then the whole room will be having 6 to 8 air exchanges in an hour or a given period. So in that way they will say, but usually like if you use the word air exchange and that cycle, that is sufficient. Please go on. Yeah. So here with regards to water supply, it is essential that like what is the source of water, what is the way in which the water is collected or where it is collected, transportation from the place of collection to the place of consumption. If at all, if they are storing it, what is the duration of storage, place of storage, type of storage, and how they are consuming, whether they are using a tap for it's a kind of a like a container, or whether they are going using this water purifier which gives continuous water, or whether the type of the water purifier, whether it is a UV reverse osmosis or a combined UV RO and some other technology for the water purifier. Why it is important is like again from all these questions that you are asking and presenting should be relevant to the case that you are presenting. So coming to the topic that you are talking about in terms of hypertension, so what does the type of water, whether is there any link between hard water or soft water on hypertension, or more importantly cardiovascular diseases? Is there any link?
So the salt content of water might have a
Okay.
link on cardiovascular diseases.
Okay. So you're basically referring to salt content as in hardness. So depending on the dissolved solids or the dissolved solutes, depending on whether the water is hard. So because like you might have heard about the adage, Mediterranean diet, soft water, or what they consume will have a bearing on the arterial resilience, thickness, and also the potential for building up of this plaque inside the interarterial lumen. So in that sense, the water source, if at all, if the person is getting a borewell water from let's say 600 or 800 feet depth, certainly the solute load will be relatively higher. And if they consume it without passing it through an RO filter or some kind of a filter, there might be some effect on the individual's health and well-being. So that is important for us to know what the water they are consuming. And also with regards to hand hygiene, the use of toilets. So these are all typical questions depending on which case you are presenting will be asked. So if at all, if it is let's say a diarrheal disease or a gastroenteritis, certainly the question will focus more upon the availability of a sanitary toilet or a sanitary latrine, and the use of water seal, what are the different types. These are conventional questions that would be put in over there. The last 2 or 3 things with regards to waste disposal, again it is important, especially from an urban solid waste management perspective. The question will be related as to how in an urban area the waste is being collected, transported, and the final destination, what is happening. So can you just briefly, we are digressing, but it's important, tell about the way in which in Bangalore city the waste is being managed, the solid waste management, the cycle, can you say, from the source of generation to its final disposal?
Then I'm not sure of this.
Okay. So this is where, I mean, like the others on the call should understand that many a times we will be very focused on the case that we are presenting. So ask me about hypertension, I can talk, and you are asking about waste management. But in a clinico-social case, that is where the tilt or the shift happens, because solid waste management is a part of your environmental history presentation, and the house to house or door to door collection through Paura Karmikas has been standardized in Bangalore urban areas. So there is nothing like people throw the waste indiscriminately. There is daily house to house collection, and they are insisting on segregation of wet waste, that is the green waste, and the plastics and the other general waste from the household. And also the biological waste, masks and other things, especially in the COVID, has been segregated, and they are having a frequency of collecting these waste. So green to be collected daily, probably in some areas Tuesday and Thursdays they're collecting the dry waste. And upon collections, the from each of the roads, they will be having the hand vehicles or the small auto tippers. They go to the central location in that ward where there will be a compressor which will compactor which will compress and push the entire volume and quantity of waste into a smaller thing, and that will be taken to landfills. So the landfills are the final destination where the waste will be dumped, and it will be covered by layers of soil, and that will undergo its own process. So the reason why segregation is being insisted is for the fact that the green waste is biodegradable, and the other 60 to 70% of the waste that is coming as solid waste or general waste from household level comprises of this plastics and other non-biodegradable material. So the quantum of waste in biological landfill, I mean, in landfills, which cannot have any kind of a biological degradation, is causing to this problem of huge dumps with solid and the groundwater and so many other deleterious effects are happening. So please be aware of it. And when you are presenting even a clinico-social case which has no bearing on these things, it would be asked. So have a knowledge of this, and also the dog menace and other accessibility issues. So when you say that the person goes for a walk, the simple question would be, is there a park in that area? What time does he go? If there is a presence of street dogs in that area, is it safe for the person? So all these things are very relevant. So when you're talking about a clinico-social case, these unrelated but yet connected things will be asked.
Yes,
So
sir.
yeah, the last thing you have written is about the nearest healthcare facility is 1.5 kilometer. In a rural area, it will be having more significance for the reason that we have a sub-center, the primary health center, and a community hospital and the district health center and other private healthcare facilities. But in an urban area, by and large, the accessibility will be well within 2 kilometers, depending on which level of care they are referring to and where they would like to go. So this is a point for accessibility of healthcare services for that given individual. Okay, good.
Yes.
Please proceed.
The general examination. Mrs. XYZ was examined under adequate light and was conscious, cooperative, and well oriented to time, place, and person. She was examined on the 22nd of this month. Her height is 170 centimeters and her weight is 78 kilograms. Her BMI is 26.9 kg per meter square. Her vitals are recorded as follows. The temperature was 97.8 degree Fahrenheit. Her pulse was 78 beats per minute, which were regular in rhythm, normal in volume, character, and the vessel wall was not palpable and the peripheral pulses were felt. The blood pressure was 134 over 80 millimeters of mercury, which was measured in the right arm on sitting position. The respiratory rate was 20 breaths per minute, and there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema.
Okay. So here, the common questions that would be asked is with regards to the weight of the individual, because being an adult, the height is by and large fixed, and the BMI. So do you think by just looking at the weight, do you think the person is overweight?
Yes, sir.
So what is ponderal index?
So ponderal index is weight. Sorry, it's a height and height upon cube root of weight.
Okay. So when you subtract this 170 and minus 100, the height in centimeters minus 100, that sometimes is also taken as the appropriate weight for that given individual. So how do you calculate the ideal weight for an adult?
Um, I'm not sure, sir.
Okay. So there are nomograms or normal height scales and weight for height, weight for age, even in adults. So there is a table which you can see that, like, given this height, what should be the weight of an individual, male and female. There are nomograms that have been created based on that. But a much more easier thing is calculating the body mass index. So given this 26.9 kilograms per meter square, so the BMI is calculated as weight in kgs divided by height in meter square. So when you compute it, you have got 26.9. So what is the classification of BMI for a given individual?
So there's WHO classification and there's also a separate classification for the Indian scenario, sir.
Mhm.
According to WHO, it's less than 18.5 would be underweight or like undernutrition. If it's between 18.5 to 24.9, then that's normal. Between 25 to 29.9 is considered as overweight, and over 30 would be obesity.
Okay, so and there is also a category morbid obesity. So why is the body mass index an important determinant for hypertension or any cardiovascular diseases?
So, obesity is one of the most significant risk factors for hypertension and cardiovascular diseases, sir.
Yeah, very good. But what is the pathophysiology of it? What happens?
So, obesity can cause insulin resistance.
Very good.
And another thing is that when there is elevated lipids in the body, they tend to cause endothelial damage and dysfunction,
Very
which
good.
can then result in the pathophysiology of hypertension, where it causes hypertrophy of the smooth muscles and then narrows the vessels down. So atherosclerosis is one of the processes that happen.
Very good. So this is the way you should approach for correlating a physiological function with that of a pathological process. So like the adiposity and the weight gain that you see, the fat itself alters the metabolism, and the insulin resistance will heighten, thereby increasing the free glucose, which might have a effect on the metabolism, as you told, both from the arteriolar and the vascular component of it, and also the circulating free radicals and the sorbitol mechanism, sorbitol metabolism, which might have a bearing on the overall metabolic component of that given individual. So then coming to the measurement of blood pressure. When you're presenting a case of either a cardiovascular disease or hypertension, the most important thing that is asked or probably will be asked to demonstrate is how you measure the blood pressure. And given the current non-use of mercury sphygmomanometers, because earlier the questions would have been on what is parallax error, how would you calibrate it, how do you set it. Now, most or many of them use digital sphygmomanometers or the digital BP meters. So, can you just explain the way in which ideally it should be measured, the blood pressure measurement?
So, with respect to the device or the whole.
The whole process. How will you measure the blood pressure of a given? How did you measure this lady's blood pressure?
So this was done at home.
Very good.
So the prerequisites were that the room in which it was measured was silent. Then she did not have. I mean, she not go for exercise 30 minutes before, or she did not drink caffeine before the measurement.
Okay.
And she was made to relax for 3 to 5 minutes before taking the measurement.
Very good.
Then she was seated on a chair and her back was supported by the chair.
Very
Her
good.
arm was placed on the table and it was at the mid heart the mid heart level.
Mm-hmm.
Then the cuff used was of the appropriate size.
Mm-hmm.
I used the mercury sphygmomanometer, sir.
Very good.
So that covered the whole of her arm circumference, sir. It was
Okay.
placed an inch over the cubital fossa,
Mm-hmm.
and the okay, I had to take the measurement, so I made sure the room was silent and that she was relaxed,
Mm-hmm.
and then I took the measurement using the sphygmomanometer. It was
Okay. How many measurements did you take? And what was the, I mean, like systolic, whether it was the beginning of the, can you talk a little bit about the Kortkopf sounds?
So there are four phases of the Kortkov sound, sir. Phase one is the tapping sound. Phase two is when there is this swishing sounds. Uh, phase 3 would be this. So there'd be these. I'm not sure of phase 3, and phase 4 would be the muffled
Muffling.
sounds.
Hmm.
And we start taking the systolic blood pressure from when we hear the tapping sounds,
Okay.
and then we consider the diastolic blood pressure from what point or what level the sounds would disappear.
Okay. So what is pulse deficit?
Not sure, sir.
So suppose the person has a very high blood pressure, let's say 220. So in such this thing, like, is there any way wherein you will be able to sort of like correctly identify that extremely high systolic?
Not sure, sir.
Okay. So when you are measuring the blood pressure, so the first time when you like deflate using a sphygmomanometer, so you deflate it slowly, and the return of pulse you will be seeing it as the one of the stages. So usually you tend to inflate 20 to 30 above that, and you measure the blood pressure once again. So this gap you would find between the sounds and the return of the pulse is very important, especially among people in hypertensives whose systolic can be very high, and there is a chance of missing because there is a silent gap in between the two these things. So that is important when you are measuring the blood pressure. And with regards to number of readings, how many readings is required for you to average it?
So minimum 3 readings, sir.
Okay. So do you take an average of three, the lowest of three, or how do you do that?
So take the average of the 3 readings.
Suppose the first reading is extremely high, the second is extremely, oh, I mean like low, and the third one is somewhere in between. Don't you think that it would be like sort of like messing with the actual reading?
Yes, sir. Then we take the higher 2 readings.
So just please, I mean, like probably when you are discussing the last phase, we will look at the classification and also the way in which both the JNC8 and the Indian Association of Cardiovascular Diseases, they give the protocol. So we'll look at that. So please carry on, present.
Yes, sir. The systemic examination, the S1 and S2 were heard and there were no murmurs. A respiratory system examination revealed normal vesicular breath sounds that were heard bilaterally and equally. There was no focal neurological deficit, and the abdomen was soft and non-tender.
Okay.
So the diagnosis is hypertension clinically. The clinico-social diagnosis is that Mrs. XYZ is a 44-year-old woman who is a known case of hypertension since 2 years. She's on regular medication since 1 year and her blood pressure has been under control. She has routine checkups yearly once. There is history of hypertension in her family, and the primary level of prevention failed here.
Okay, good, Priya. So when you are saying clinical diagnosis is hypertension, how do you classify hypertension? As in, like, is it based on primary, secondary? Priya, you able to hear?
So the voice is getting disconnected, sir.
Yeah, we couldn't hear. How do you classify hypertension?
So we can classify it depending on the underlying etiology as primary or secondary hypertension, sir.
Hmm.
Primary hypertension would be when there's no known cause of what has resulted in the hypertension. But secondary would be if the patient has an underlying disease which would have resulted in hypertension, that would be secondary, like a renal cause or an endocrine disorder or obesity, which is associated with obstructive sleep apnea.
Okay, very good. So in that sense, like the classification of hypertension usually will be based on multiple things. So when you're saying that like it is either by the organ or by the severity or by the phases of cardiac cycle or by etiology or by the duration or incidence. So in terms of like when you say the severity, we can say that it is normal or elevated blood pressure or stage 1 and stage 2. When based on cardiac cycle, systolic hypertension and diastolic hypertension. In terms of etiology, based on the underlying pathophysiology, renal hypertension, vascular hypertension, or tumor, pheochromocytoma, or any steroid producing tumor, or aldosterone, or some kind of a etiological underlying cause can cause. And duration, it is transient hypertension or a long-term hypertension. So like that, there are several ways based on the different components we can classify hypertension. And this term essential hypertension is no more being used, for the reason that like earlier there was a thought that like as someone aged, the rigidity of the arteries is going to increase the lateral pressure on the walls, and that is essential. So but thanks to the several developments that have happened, so the resilience or the this thing of the arteries is so good that if there is auto regulation and the various ways in which the blood pressure is uh, kept at that range is good, then there is nothing like essential hypertension, and it happens as a consequence of one of the underlying pathologies. Okay. And when
Yes,
it
sir.
comes to uh, clinico-social diagnosis, that is what I was going to say. I think probably someone asked. So clinico-social diagnosis is the part of your first this thing when you would have told that like the person is such age, living in a nuclear family, working as someone with no known risk factors or risk factors, staying at a given area with these many physical environment, having controlled or uncontrolled hypertension on medication with no known end organ involvement. So this would be the clinico-social diagnosis, where we are talking about the person's family, family composition, socio-economic status, the history that, I mean, like the consumption of personal history that we would have spoken about, the residential environment, occupational environment, the stage of the disease, comorbids for the disease, current treatment, adequacy of treatment in controlling the current symptoms, and whether the person is able to have access to care. This entire spectrum is the clinico-social diagnosis. Can you attempt it, Priya, for this case?
Yes, sir. So Mrs. XYZ, who is 44 years old and a known case of hypertension, who belongs to a nuclear family, which is comprised of four people. She hailing from Whitefield in Bangalore. Uh, so should I tell out even the socioeconomic status?
Oh,
The
see, that is why you needn't have to repeat Whitefield of Bangalore. Residing
just
in an urban area with in our own house. So again, you need to pick up those components of the history that you would have mentioned, which has a bearing on the disease. So no need to say that there is no pallor, no ictus again in clinical social diagnosis. It is to pick up the positive thing which might have a bearing on the disease, or absence of a comorbid or a complication. Because if this person does not have diabetes, that itself is a good thing. Have you made any attempt at knowing whether she is having diabetes or not?
yes, sir. She's not diabetic.
Is not diabetic. When was the last sugar levels done?
3 months back, sir.
Okay. And what was the fasting or the postprandial?
So I don't remember the exact values, but they were less than the fasting was around. It was less than 100, sir, and
Mhm.
postprandial was around 100 and 130, I think.
Okay. Okay. See, because like another thing you would have to be cognizant of the fact is like she is having a higher BMI, obesity, and hypertension, which might be a sort of like a precursor or the risk factor for her to develop Diabetes. Was there any family history of diabetes?
No, sir.
Okay, that's very good. So the last line you have written here is primary level of prevention has failed. So we have three levels of prevention and their own modes of intervention. That is primary level of prevention, secondary level of prevention, and tertiary level of prevention. So for primary level, we have health education and specific protection as a mode of intervention. For secondary level of prevention, we have early diagnosis and treatment. For tertiary level of prevention, we have disability limitation and rehabilitation. So in this lady who is 44 years old, why do you think primary level has failed?
So because one is her lifestyle, sir.
Mm-hmm.
Because until like a month ago, she was not, I mean, regular with her exercises, and or even before that. And another thing is, it's a sedentary lifestyle, considering that she's always at office. Her diet is something which was not right, sir. Like, it was always consumed at the office itself, so she has no control on what she eats. The sleep is also not adequate enough, and there are a lot of stressors as which could have resulted in hypertension.
Very good. So usually when we say primary level in non-communicable diseases, hypertension, diabetes, and stroke, all these things, we have one more level called as primordial level. So that is before the emergence of risk factor for that particular component, we call it as primordial level of prevention. So in this person, usually when you are saying the which level has failed, one level before that would have certainly failed for it to reach to this level. So it is a hierarchical grading. So if you say secondary level has failed or tertiary level has failed, it means that both secondary and primary have failed. So this you need to keep in mind. So when you're talking about primary level, it is not just at this stage, last year, or she's not exercising or food. It is from the time from adolescence, because there is a concept called as tracking in hypertension. Have you heard of it? What is tracking?
Yes, the blood pressure values, I mean, the blood pressure is recorded since childhood, and then that continues up to adulthood, sir. So if the blood pressure values were low at the time of childhood, it's likely that the same thing's going to continue. And if it was high, it's probable that it could be higher when the child becomes an adult.
Absolutely. So that is a way of understanding the progress of blood pressure, because it has been shown that there is a link between the higher the blood pressure in early childhood and adolescence has a bearing on later when in an adulthood where the disease will manifest. So the dietary habits, the exercise habits, all these are learned behavior or acquired behavior from adolescence and the school and college going age. So in that context, the system or the preventive ecosystem has failed to inculcate a healthy lifestyle despite a known risk factor. That becomes very important because there is a family history of hypertension. So with a known risk factor for hypertension, this individual should and would have been better off if they had practiced maintaining their body weight, maintaining their other activities which might have been congenial for avoiding or preventing it, the onset of hypertension at a maybe a later stage. They could have postponed it. So the primary level has failed here is a okay thing. Yeah, please go on.
Um, So, this is a list of investigations that were done 3 months ago.
Mhm.
The complete blood count, hemoglobin, blood sugars, lipid profile, and thyroid function test.
Okay. So here, why do you think a person with hypertension would require a complete blood count?
Uh, Hypertension.
It's not an infectious condition.
So, anemia is a significant thing. I mean, although it's not related to hypertension per se.
No, it's about, if at all, if you, I mean, like hypertension, if you want to link, as we looked in the previous slides about the causes for hypertension, usually there might be a renal dysfunction which might have a bearing on the RBC count, as you told, the anemia part of it. So, for that reason, there might be some clues with regards to any underlying blood pathology or hematological pathology which might have a bearing on the current this thing. And also if there is let's say like low this thing, like I mean if there is a renal related pathology, there might be variation in the RBC morphology and other things which will be related to this thing. But ideally we don't usually ask for complete blood count in individuals with hypertension. Sugar levels fine, and lipid profile, what should be the frequency of getting this lipid profile done in an hypertensive patient and why?
So once a year,
Mm-hmm. Once in a
because
year, or is it once in 6 months or quarterly?
um, so from the, I mean, this is based on the national program. I found they do it once a year.
Okay. So we will come to the program a little bit later, but the lipid profile and the sugar levels will depend on the control or the parameters of the report. So if at all, if there is any dyslipidemia, hypercholesteremia, triglyceridemia, or change in the HDL and LDL ratio, then it will be repeated once in 3 months. If it is under control but elevated, once in 6 months. If it is absolutely in the normal range for that given age and gender and that individual, then it is annual. So the categorization is more on a clinical basis as a lab support to identify the secondary complications early on, rather than it has to be done just for the sake of doing it. Okay. And similarly, thyroid function test. Can you just link the thyroid function test with that of the hypertension?
So thyroid, hypothyroidism can be associated with hypertension, sir.
How and why? What is the pathophysiology?
Uh, so I'm not sure of the
Okay.
pathophysiology.
Fine. Because see, this is where like you need to be clear that when you have put an investigation or when you have mentioned something, the question will certainly ask like, why is it important? So that part you need to be sort of like clear about, or while you are presenting or while you are this thing, put a line or in your notes. And these are all, once if you write it down, it would be clear. So please mention it, and there should be a justification for choosing a particular test, whichever test that you are asking for. Please proceed.
Yeah. So the recommended investigations, in addition to what were already done, would include serum electrolytes, the urine tests for proteins, ECG, and also a fundus examination.
Okay.
GI.
So I will not spend too much time on this, because serum electrolytes, again, you need to justify why and what of it. ECG, yes, but again, it would be helpful when you say about the recommended investigations. It's in the form of a chart as given by the Joint National Committee 8 guidelines, which specifies that with comorbids, without comorbids, with end organ involvement, and without end organ involvement. So that matrix will help to say that if an individual is at a risk for something, then you need to have it at that frequency. Ophthalmic, for example, hypertensive retinopathy. Similarly, the renal function test is something which is missing, because we need to know whether the person is going for hypertensive nephropathy with altered creats and blood urea nitrogen. So these are all end organ involvement, because both in diabetes and hypertension, it's not the disease per se, but it's the effect on the microvasculature and the major organs, which will show problems in terms of retina, in terms of cardiomyopathy, in terms of nephropathy or neuropathies, which will be required to be tackled by routine examinations to prevent subsequent complications. That is the secondary prevention of early diagnosis and treatment to avoid subsequent complications. So please
Yes.
proceed. Next.
So the socio-economic factors that influence this condition.
Mm-hmm. Okay.
So am I audible, sir?
Yeah, you are audible.
Because the
Please go
screen is
on.
stuck.
You're audible
Yes,
now.
sir. So The fact that she fasts once a week and does not consume any other calories except for milk and water is something that favors illness.
Favors illness, favoring it. See, again, in terms of like when you're saying favoring illness, you should understand that this is contributing to the disease, is what is the meaning. So, I mean, are you implying that like fasting once a week has a deleterious effect on hypertension, or is it helpful for I mean, like managing hypertension?
So I'm not sure how fasting is having an effect on hypertension, but she's not consuming any calories or there are no nutrients for that day,
Now, it might
which
say
would
like
make her.
intermittent fasting has been shown to be helpful in terms of weight reduction and mental health, and for the toxin theory part. And several diets have been there with with which support this intermittent fasting or once a week fasting, which they say that like this only water and other things will help you to detox. But as you rightly told, there are no specific evidence. Only thing is it might have a bearing on our weight and other things, and not directly linked to the thing. But no, my contention was that heading favoring illness. When you say favoring illness, it means that it is deleterious. So we need to have an explanation for that, which even I am not very sure. So I wouldn't put it over there. So we'll just say that like fasting once a week might have a bearing on our weight, which will help in I mean obesity management or something. Okay.
Yes, sir. So her personal hygiene, she takes bath every day. She washes hands. Her nails are clean and cut. That is a positive factor as far as the
Mhm.
general hygiene is concerned. That would help in preventing other diseases.
Okay.
Then, with respect to her occupation, it is stressful, results in less sleeping hours with 8 to 9 hours of screen time, and the fact that she has to travel up and down, all this could act as a stress. I mean, stress related, and it's also the fact that because of this, she was not able to consume. I mean, take the medicines on time or give importance to her diet, so that could have resulted in worsening of hypertension or contributed to it.
Yeah. So here, it's very important that we spend time on this occupational role of occupation in causation of disease, management of disease, and treatment of disease. Especially from hypertension point of view, IT professionals, when we say it's stressful, you need to be very clear about whether the occupational environment, by virtue of the job, by virtue of the interaction, interpersonal relationship between the peers, boss, and the subordinates, or the entire workplace ecosystem is stressful. So that will be what is required for us to understand in terms of like whether it is stressful or not. The second thing is the deadlines and the work pressure itself, where the resources for conducting or doing a particular activity might not be adequate, and they will be required to deliver against a ticking clock. So that might be stressful. Third is with regards to traveling hours, whether it is a cab or a coach or the person has to drive. So if the person is driving on their own in a four-wheeler or a two-wheeler, that is stressful both from a physical point of view and the mental psychological health point of view. So this has to be very clearly articulated when we are talking about role of occupation in causation of the disease, in management of the disease, and treatment of the disease. And diet, you have absolutely told that like whether the consumption of fruits and vegetables. So the dash diet, when you're talking about it, you will be spending a little bit time on it. And lunch, which is given by the office, certainly might be curated by a dietitian, but seldom it caters to the nutritional dietary requirement of all the individuals concerned. Fine. So please proceed.
Yes. So the knowledge and attitude of the patient. So she has rational knowledge about the cause, the cure, and the prevention of the disease. That is when I asked her about whether she knows what would have resulted in her hypertension and whether how it is cured and how she could have prevented it. She has adequate knowledge about the three. And regarding the attitude, she is taking her medicines on time, and she is right now she's focused about her diet and the exercise, so she does have a positive attitude about it as well.
Mm-hmm. Okay. Again, this is a very important thing from a clinico-social point of view, where having adequate knowledge, because when we talk about educate the patient, it is important to address all the three domains. We have cognitive domain, affective domain, and psychomotor domain. So the cognitive domain refers to the knowledge. The affective domain refers to the attitude. One second, I'm getting a call. Please hold on.
Yes, sir.
Miss Priya, you're doing wonderfully. Okay, answers are brilliant, and it's one of the best PowerPoint presentations I've ever seen.
Thank you,
Priya, can
sir.
you hear me?
Yes,
Really,
sir.
really proud of you,
Thank you,
and
sir.
to say that you are the core member of the White Army, and perfectionist Priya. Wonderful. I'm really enjoying, and sir's questions also. Both the discussion going on really well. We are learning a lot through.
Yes, sir.
You're tired or something?
Sir, the screen is getting stuck and the voice is breaking.
Okay. Now we'll close it in the next 5 or 10 minutes. It's already in 1 hour 17 minutes. So we'll
No,
close it
sir,
and
sir. Time is not a constraint. Please, sir. We are really enjoying this session. Please, cover the entire topic, sir. Please.
yeah. The thing is like I certainly have to compliment Priya. I was
Yes, sir.
trying to do that in the end, which Kishan did. We are really like happy that the presentation is very well structured, and also the PowerPoint slides that
Yes,
have
sir.
been prepared
Yes,
are
sir.
excellent.
Yes,
So
sir. Yes, sir.
both are very
And she
good.
has put lot of effort, sir, for this day and night. She prepared a lot for this. I personally know this how much effort she has put. And
Yeah,
sir,
yeah.
discussion the questions also are very standard and very good quality questions. Sir. We are learning a lot through this discussion. Please continue, sir.
Sure, sure. Thanks a lot, Kishan. So, like I was talking about the domains of health education for a particular disease. So, we have cognitive domain, we have affective domain, and psychomotor domain. So, when we are trying to provide inputs to that individual, it refers to not only increasing their knowledge about the causation of the disease, the cure or the treatment of the disease, or prevention of complications or managing at that level. It is not that like you might sort of like talk to this person and say that what causes. Being an IT professional, she would have googled it and had got multiple sources of information with regards to the knowledge. But what we want to impress upon the individual is the attitudinal component of converting that theoretical concept into a practical use, which is the psychomotor domain. So if she knows that, look, walking or brisk walking or physical activity is good for me, converting that into an activity which he would do and adopt it as a lifestyle is what is very important. So this knowledge, attitude, and practice part of the patient is very important, wherein we are assessing both for an acute disease like in tuberculosis, knowledge about cause of disease so that they are not going to spread it, knowledge about and attitude about it. If they have a fatalistic attitude saying that I care I'm about I mean like it doesn't matter to me, then no amount of good medicine, good treatment or this thing will have a bearing on the disease management in the long course. So it's very important that both the knowledge and attitude is very well calibrated for translating it into a desirable practice for benefiting the individual in preventing and managing the disease. Please go. Next.
So the management of hypertension with respect to this patient, uh, For the individual level, lifestyle modification is a very important aspect, where I would advise her to continue her daily exercise. However, reduce the screen time, sleep early, take short breaks in between continuous working hours, a few minutes of meditation, and importance of weight reduction. And with respect to the diet, DASH diet would be very significant in terms for hypertension, which is dietary approach to stop hypertension, where she'd be advised to reduce the salt intake and consume more of green leafy vegetables and fibers in her diet, and also add nuts and fruits. And another thing would be to take small meals at regular intervals. And self care, which would include home based monitoring of blood pressure and adherence to the medications that have been prescribed. Because, as such, 1 year ago, she was not adherent to the medications, and that did result in one episode of hospitalization. And would also like to advise her on some of the warning signs in case she turns out to be non-compliant, and then she needs to get herself checked up. And routine health checkups are also important.
Excellent. Do you have a part B to this? Okay, individual, family, and community you will be saying. So you
Yes,
finish
sir.
that, then we will come back. Yeah.
The management at the family level.
Mm-hmm.
Yes, sir. So at the family level, the family should be educated on about hypertension first, and then about how they can motivate her to take a proper diet and take medicines on time, and also take her for routine health checkup. Accompany her during walking, reminding her to take breaks and to sleep early. And family members are also to be screened for hypertension because there's a history of hypertension in the family. And at the community level, primary modes of prevention, which would include health education, lifestyle modification, behavioral changes, and self care, and screening and periodic health checkup, followed by early treatment in case they've been diagnosed, is very important.
Excellent. Shall we just go one slide back at the individual level?
Yes, sir.
So here, when we are talking about lifestyle modification, see, this entire thing is a theoretical framework for managing hypertension, which is excellent. So you have given like what should be the lifestyle, what should be the diet, and how small meals can be taken, self-care, what should be done, and warning signs education and routine health checkup. So usually this theoretical framework should be made practical and appropriate for the given individual. So you have spent sufficient time in understanding the individual in their own domestic environment. So in that context, whenever you are giving an advice from a practical point of view, if you were to be a community physician talking to this patient, you would say, look, Lata or Rama or whatever the name of the person, please do this once you wake up. Have coffee or tea at this time with 2 biscuits. At 11 o'clock, you do this. You can eat sprouts for your meal, for your lunch, what you would eat. At 3 o'clock, half cup of tea with one uh, biscuit. 7, 6:30, 7, 7:30, an early dinner. So you need to have a very specific, quantifiable, qualitative input for managing the entire physical activity, dietary cycle, and also the supportive environment for that individual, which they can take responsibility for. When you move to the family, you are sort of like taking this concept of when we are sort of like treating a diabetes or a hypertension, the individual is not the only person who can decide about the diet. What she cooks, 4 people eat. So in that sense, the entire family, if you say low, I mean like salt restriction, she won't be able to prepare a meal without salt. So, or before adding salt, take a portion of it. So from a practical and a pragmatic point of view in a given household, it will be essential for the other members to also understand how and where they will be required to support this individual in terms of physical activity, in terms of preventing. If the person has a sweet tooth and is diabetic, if you say the buddy group or the work group to say that, look, ensure that a person doesn't consume more than what is allowable kind of a thing. So the role of the family in health and disease is very essential for management of hypertension. So quickly I will respond to some of the questions in the chat with regards to how often we should check BP for monitoring at home and for a hypertensive individual. Again, all these, whatever the response for these questions is based on the control of hypertension and the riskness of that individual to develop something. So whenever we are initiating a new patient on pharmacological treatment for hypertension, we would usually say that check it every day, twice a day minimal, so as to understand if there is any diurnal variation, and also to look at the range of systolic and diastolic. But for an individual who is settled with 2-drug regime or a 3-drug regime with no other comorbids, and the BP is by and large in a given range, then it is once in a month or once in 15 days. If there is no other event, it is sufficient. And that has to be done in a manner which we has been described. The second thing is, in a week, how many times should we check blood glucose using glucometer is another question, which is very similar, where depending on the glycemic control, if the individual is having fasting and a postprandial and the glycosylated HB in the range of let's say 6 to 6.5, then I wouldn't want them to prick every day and check just because it is available. On the contrary, if there is fluctuating, if the person is having fever, the person is taking a antibiotic, then we would say at least on a daily basis or an alternate day, you need to check. So this question on the frequency of self-monitoring or home monitoring will depend on the individual's physical, physiological, and the morbidity status and comorbid conditions, and they need to do it. So I think that has answered the question. The last one is, does the potassium rich fruits or vegetables help in hypertension management? A very difficult thing, for the reason that when you say this small bananas which are rich in potassium, does it have a bearing on it is what we will be required to see. So the dietary part of it, I'm not very confident to answer that question. So please check with a dietary this thing, and then you can take a call. So can we move to the next one?
Yes, sir.
Please continue, Priya.
So that's it. That was
That's
my
it.
presentation.
Okay, fine, excellent. So quickly, I will just tell if I mean probably sharing is not required of the screen.
Shall I stop my screen sharing, sir?
Yeah, because I just pulled out this thing presentation from the slide share. Uh, is the screen visible?
Yes, sir.
Yeah. So this has been done by Anish Dhakal, Aryan. So this is not my presentation. I have taken it from, I mean, like the Suomoto entire thing. And that is one more thing which I would like to sort of like mention it to the students who are on the call. Please ensure that when, I mean, like today it is very easy to get these presentations from the internet. So if I just type hypertension guidelines, somebody would have put in the efforts to do this presentation. So being a person to have access to this doesn't mean that if you just paste it onto your presentation and put your name, it refers to plagiarism. It means that you're taking somebody else's effort and posing, or without intent saying that like it is yours. So this comes under the category of intellectual theft. So never ever please take something from another's slide or internet or any other source which is not yours without citing or quoting. Or do like this, where the entire source is projected as somebody else's source, where you don't take the ownership or responsibility for making it. So please ensure, if it is from a secondary source or from a cited source, ensure that that thing is both cited and quoted. So this is a fairly good presentation which I picked from thousands which were there. So where they have tried to categorize hypertension based on organ, severity, cardiac cycle, etiology, and the duration or incidence. And it goes on a beautiful way in which each thing has been categorized. So if you look at this thing, like from where the category is converting it into a hypertension definition, normal is less than 120 millimeters of mercury for systolic and 80 millimeters of mercury for diastolic. Ideally, the individual should have given the source for this particular thing as JNC 8 or any other clinical guideline source from where this thing has been taken. And also, when you are measuring the blood pressure, this is what Priya has already told, but it should be well calibrated machine covering at least 80% of the cuff. Patient should rest for 5 minutes and at least 30 minutes after ingesting caffeine or any other thing which can alter the blood pressure. And it should be appropriately measured in both the things if you are suspecting any anatomical variations. So the classification is primary, secondary, and crisis, and the definition has been given for the same. And when it comes to the other classification, these are all the primary or essential hypertension, which is the most common, followed by the various other classifications. So when it comes to investigations, it is based on some primary evaluation of the patient at the first time and at the repeat this thing. So this is to pinpoint the cause or pinpoint the reason for which the individual is having hypertension. And how to target is when you're coming to the treatment part of it, when to sort of like say that this is the target I would look for this patient. So these are some of the things which are really important, because in geriatric patients, when you are trying to very tightly control the pressure, they can go for hypotension, or in terms of diabetes, a hypoglycemia, which is equally or far more dangerous than a slightly elevated level than the actual norm of normality. So when you go to some of these trials, they talk about it. And non-pharmacological management like reducing sodium intake, low-fat dairy products, maintain normal body weight, quitting of smoking, decreasing alcohol consumption, increase physical activities, and exercise. So this is the lifestyle modification which should very specifically translated to a reduction. So when you say a BMI weight reduction in this range will contribute. These are all sort of like from very good studies which have shown the attributable reduction to a particular intervention. So you can say that, like, if you do this, you will be able to do it. And there are several like American College of Cardiology risk estimate questionnaires wherein they can put in a number and they will be able to say that this is the risk and other things. And also when it comes to antihypertensive drugs and combination of those treatment, there is a separate clinical protocol. You can read from either Davidson or any of the Indian Association of Medicine guidelines. And incidentally, 3 days back, I think Kishan would be aware of it, there is a guideline which has been released by Indian Council of ICMR, this thing on standard treatment workflow, STW workflow, which is extremely well sort of like compiled. Probably you can share it with the group, Kishan, that particular thing.
Sure, sir. Sure.
So with this, I would like to stop because we are exactly at 7:30 and the class was 1.5 hours. And I would compliment Priya and the entire team who have come together for this wonderful thing. And this has been my first experience, honestly, on this platform. And I am thankful to Kishan and the White Army group for allowing me to share a little bit of the this thing subject which we are doing this. Thanks a lot for this. And if there are any quick questions, we can sort of like take it.
We had heard a lot about you, sir, but today realized, sir, what is a what is effective teaching, or how like how to mesmerize the students with the teaching, sir. It was really, sir, practical. I need not exaggerate things because I have already passed community medicine now. So, but to be frank, sir, one of the best sessions I ever had, sir. In last past 1 year, we had almost 400 sessions, sir.
Okay.
This stands out, sir. One of the special sessions we had, and you made the topic very simple and understandable for all our students. Very much grateful, sir, and we looking forward for many more sessions like this, and want to learn more from you, sir. Please, whenever at your convenience, please take some sessions for us, sir.
Please, certainly, sir.
We'll
Yeah. There's a
yes,
question,
yes.
Kishan, I would
Any
like to
questions?
answer. From an exam point of
Yes, sir.
view, what can we expect to be asked about COVID and hypertension or COVID and other PSM cases? Certainly, this would be there. What we are seeing, see, about COVID, everything is in a flux because, like today, if we say something, tomorrow the thing is changing. Plasma therapy or remdesivir use, or let's say O group being less susceptible. So the common consensus is presence of hypertension and diabetes worsens the outcome for a COVID patient because these are comorbid conditions which might have a deleterious effect on the cytokine cascade that happens, and people are sort of like having a worse outcome. So the if you look at the mortality analysis, age, the high presence of hypertension and diabetes have been very strong correlates for mortality with COVID. So in that sense, like it was very sort of like important for you to know that. And the last four questions are unanswered, is put, which is that four questions. What should okay, so does potassium rich? I told I don't know. Cutting out dairy from diet beneficial hypertension. Again, this is a very sort of like a nutritional trick question where they have told the vegan diet is supposed to be beneficial, but there have been no randomized trials as such to say that any form of diet. What has been shown is a diet which is local. When I say local, the regional diet for that particular thing consumed in a way which is traditional and natural certainly helps for that region. So cutting out entire dairy, I'm not too very sure about it. How to monitor side effects of amlodipine, atenolol, losartan, etc. given to avoid heart attack? It is not for heart attack, but it is for cardiovascular this thing. Atenolol is a beta blocker, losartan and amlodipine calcium channel blocker. So usually what happens is like there is not therapeutic monitoring of drugs in our practice. So we go by the symptomatic manifestations of the known
Exactly, sir.
side effects.
Yes.
So
Clinical symptoms will be there, sir, like lightheadedness,
yeah.
dizziness, whenever headache. So the patients when presents with such symptoms, sir, we suspect this side effects and adjust the doses accordingly, sir. Perfect.
Yeah. So are there evidence-based management of hypertension same as weight reduction and dietary sodium reduction? See, evidence refers to randomized trials which have been gone into systematic reviews and meta-analysis. So if there are several Cochrane statements with regards to salt and hypertension, in fact controversial because they have told that low salt diet can have deleterious effect. So that has been proved. So some of the tribes in sub-Saharan Africa and remote Congo Valley, where the diet is low in this one salt, have some other problems. So in that sense, like by and large, this high salt, high this thing has been a WHO phenomena in the last 40 years or 30-40 years. So each one of them needs to be examined under the meta-analysis and very good systematic reviews that have come up. And from an undergraduate point of view, I'm not too sure, but if you're interested, just check out the Cochrane meta-analysis reviews, wherein they would have very clearly told the statement, this will be beneficial, this will be detrimental. So that will be very important. And last question, would chronic allergic rhinitis have a bad prognosis of COVID? I really don't know whether
Thing
allergic
is not
rhinitis.
about bad prognosis as such, but the if they are on steroids, corticosteroids and all, if the for the allergic this thing, that may suppress the immunity and they may be more prone for COVID as such. Otherwise, there is no prognosis wise, there may not be much difference, but yeah, definitely they'll be more prone for the COVID infection.
Yeah. Fine, sir. So I think we'll wrap it up. So thanks a
Yes,
lot
sir.
for this interaction, Kishan. And
Yes.
maybe like if there is an interest, I would love to have a series on epidemiology, both the study
Exactly, sir.
designs. Yeah,
Exactly, sir. Wanted to ask the same, sir. We lag behind in this research interest as well as the like research aspect as well. And you being the head of this research department, we can learn more and in interesting manners. We can learn from you.
yeah.
So, sir, if you can do that, we'll be very
Sure,
much
sure.
obliged,
Yeah.
sir.
So what we'll have is like from see
At your
undergraduate point of.
convenience, sir. We'll plan it out, sir.
Yeah, yeah. So we'll do it from the UG perspective. More than the theoretical gyan, it should be
Yes, sir.
translatable into practice at that level. So we'll have both from exam-oriented approach to
With yes, sir.
epidemiology and using it for the small studies and
Yes, sir.
publications.
And sir, please give them some tips to also to how to do this ICMR projects for UGs and also, so that they can be involved
Absolutely.
in third year when they will be relatively free.
Yeah,
They can do these projects and all, because we have to stimulate them to do this. So being
sure.
the professor, if you tell, they'll they'll follow it, sir.
Sure, sure, sure. Okay.
ಶಂಕದಿ
So
ಶಂಕದಿಂದ
thanks a lot.
ಬಂದ್ಲೆ ತೀರ್ಥ ಅಂತ ಹೇಳ್ತಾರಲ್ಲ ಸರ್.
But the colleges should also have an ecosystem to support that. If they say that we don't give you attendance, you just do the research, doesn't work that way. Let's see. And anyway, once again, I would like to congratulate Priya for an excellent presentation and to the rest of the team who were there. Thanks a lot. And I'll sign off. Thank you.
Thank you, sir. It was indeed a comprehensive
Sure, yeah.
clinical test. The discussion was very useful for us. Thank you so much,
Thank you
Dr.
so
Nanda
much,
Kumar,
sir.
sir, for teaching and guiding us. We are ever grateful to you and need your blessings, guidance, and support throughout. It was a great effort by the presenter, Ms. Priya Ashok. We could learn a lot because of your well-prepared presentation. Thank you, Ms. Priya. We also thank all the participants who are enthusiastically answering and were actively involved. Thank you, one and all.